Good morning to all of you in the Far East and down under Australia and New Zealand. And for all you folks in the Middle East and Europe, I have no idea what you're doing up at this hour, but thanks for joining me. And good evening to those on the East Coast of the Americas, and good afternoon to the West Coast in Hawaii. I'm Marty Jablow, and today we're going to be talking about reconstructing broken down and endodontically treated teeth. This is a big part of most of our practices, and there's some basic fundamentals that sometimes get lost and things change. We were taught things in dental school, and they may not be true today. So we're going to take our steps through reconstructing these teeth, and we'll go through some cases, and hopefully you'll learn a little something in the process, or maybe I will too. So I'm America's dental technology coach. So the first thing somebody wants to know is, why is there a tech guy, somebody who's used to dealing with computers and lasers and all the latest and greatest, talking about basic crown and bridge? Well, the reason is I'm no different than you. I treat patients every single day. I put the gloves on, I delve into their mouths, I have the same problems, the same issues that all of you have. And hopefully, we've got some good ways to manage these cases nowadays, better than what we were taught back, at least when I was in dental school, which was quite a few years ago, 1986. So it's been about over a quarter century. And I have seen things change tremendously. And what I was taught was good information, but it was good information for that time. It may not be the most appropriate information for today. That's what we're here for. See what's current, but some of these things that are current still rely on some of the basic tenets of crown and bridge that we were all taught in dental school. If you've got questions for later on, during the presentation, if I can see your question, sometimes I get ahead and I can't see it on the screen when you type it in. I will get to them at the end. If I catch it during the presentation, I will answer it. But if you have a question for afterwards, by all means, get a hold of me at marty@dentaltechnologycoach.com. You can get a hold of me through my website, dentaltechnologycoach.com there, and happy to answer a question on anything, whether it be regular dental technology, the beep and buzz and stuff, or things that we presented here, or just ask me what I'm doing with materials or what I'm using. Happy to answer those questions. You can also follow me online. You can catch me on Twitter, Facebook. I run a dental blog that most of it's about the latest in dental research. Kind of scour the internet and try and find the latest stuff and present it to you, things that I think would be interesting. And then this way, on a daily basis, you can check in and see if it might interest you. So every so often there's really some great research being done all over the world, and we don't all get those journals. So I've got this nice little way of kind of grabbing all stuff from all over and finding what might be interesting. And at least it's interesting to me, and hopefully if you check in at blogspot.com, you'll find it interesting to you. And most of all, I want to thank Voco, for if it wasn't for them sponsoring tonight's webinar, I wouldn't be here. And neither would you. You'd be doing something else. But we're going to spend about 40 minutes, 45 minutes learning, and then we'll open it up to questions. But again, if you have a question, go ahead and type it in the box. I don't have a problem. If I can see it, I will answer it at that point, but I'll definitely get to it at the end of the presentation. Either way. So what's the standard of care? Well, in the United States, the standard of care can vary. It's really a legal statement, not so much a treatment statement. And what we talk about is, endodontically treated teeth when they're broken down. And in most cases, the standard of care is to do something to that tooth, and it's either a core buildup or a post-in core. And that's what's required to give us enough tooth structure to get us that resistance and retention form that we were taught about, so that we can successfully place a crown or use it as an abutment on a bridge, or restore that tooth back into function, That's really what we're talking about. And that may be different in different places, and I know the standard of care was different when I got out of dental school, at least in my opinion, than it is today. So we go back in time, and I could not find an instance in the 18th century of a radiograph, obviously, and this is the closest thing I could find, which were, silver points. And, we go back that long, and Dr. Hoffman there was using hot wires for pulpal cauterization. And that's kind of what this reminded me of this kind of buildup. And if you see this was a buildup with silver points, and somebody stick a couple of pins in it. And when I was in dental school, they used to show those pictures of radiographs with a tooth that had 1 million pins holding it together. And, we all used to laugh, and occasionally I still see things like that today that come in. Some of them have withstood the test of time, and you can't knock success. But other times, they fail just like everything else, and we have to then move on to something that's better. So back to 1869 and Dr. Black. And Dr. Black, again, father of modern dentistry, and I just was doing a presentation in California last weekend, and we talked a lot about Dr. Black. And Dr. Black gave us wonderful techniques and things that he used to move dentistry forward. But the reality is, I know if Dr. Black was here today, he would not be expounding some of the principles that he did back then, because the equipment was different. The materials were different. I mean, there was no bonding back in that era. So they talked about, look, filling a root canal with gold foil, and they put a bolt into the tooth, which we would call a post today, and then they kind of fit a denture tooth to it. Well, seems very primitive, but that was state-of-the-art dentistry there. But when you think about it, in many ways, we're still doing the same thing. But then we go a little further. And Dr. Richmond here introduced the cast post-crown technique for endodontically treated teeth. And in many ways, we still see those today. I still see them in some of my patients' mouths. That same technique that was done. Some of them have failed over time, and we have replaced them. And others are still active in the mouth, 20, 30, 40 years, maybe even 50, some of my patients who are getting up there. But it has been a tried and true and tested successful way to restore endodontically treated teeth. So when we have these broken down teeth, usually there's some from trauma, some from caries, but whatever. We've lost significant amounts of tooth structure. And when I was in dental school, we were trying to keep those access openings a little bit smaller than we do today, because we open them up for our rotary files, and we need straight paths. So we get a little bit more tooth structure lost. And we were sacrificing tooth structure, and we still do at times. In many cases, if you see that anterior tooth there on your right, there's very little left. All that's left is a root. Yet we're presenting with this all the time. Actually had 3 patients just the other day walk in on the same day with similar type of situations. But we also get to these type of teeth where we've had good restorations in place, sometimes for many, many years, and even over a decade. And then at some point, the tooth fractures. And then we have to wonder, what do we do? What's the next step here? How are we going to restore this tooth? And, the more tooth structure that we have, the better. But as we lose tooth structure, we always have to remember that that's the basis for the retention of these crowns. And you need that tooth structure. It's very, very important, because without it, you do have failure. So what affects what we do? There's always a choice. And only time tells us if we made good or bad choices when it comes to our dentistry. Like I said before, the more coronal tooth structure we have, the better. You have to think about your long-term prognosis. The options that we have today are totally different than the options that we had years ago. What we have in terms of the materials, the posts themselves, and even the treatment, do we restore a tooth or not, have changed in just the 25 years that I've been doing dentistry. We started with cast posts. We have prefabricated posts. I was taught cast posts in school. I don't do many of them anymore. In fact, I don't do a lot of posts to start with because we found that posts, may not be the best thing for a tooth. But we have different types of posts to solve different types of problems. I was taught they were supposed to strengthen teeth, yet we now know that posts do not strengthen teeth. We want to keep as much dentin as possible, so when we start flaring these canals, trying to put bigger and bigger posts in, we can have more and more failures. And here's a perfect example of something we've all seen where there was not enough tooth structure left. The only thing that really was supporting the prosthesis was the post, and eventually through just the forces of occlusion, the post shears off and breaks. And now one of the things I hate to do is trying to dig out a post, because at that point I'm compromising the tooth. I'm literally taking more and more tooth structure in most cases to try and get that piece out, and then I wind up placing even a larger diameter post in the tooth, further weakening the root, all the things that go with it, and you have to tell the patient there's a greater chance of failure here. And that's not something we like to tell patients, that we're going to fail. It's not the thing dentists like to talk about. But treatment decisions are extremely important. Do we have enough structure to restore that tooth? Is it going to be there long term? And we do endodontics, and we may do a core buildup or a post and core and place a crown on it. If not, we have other options. You may extract the tooth. You can place an implant. We have a lot of different things now that come into play. We used to try and save teeth at all costs because we didn't have good methods to replace them. I remember when I first got out of dental school, we used to see these amazing perioprosthodontic cases, saving all of these periodontally involved teeth, and some amazing work that was being done to do that. Well, we don't really talk about that much today. My periodontist is sitting there saying, why would I do perio surgery and take away a couple of millimeters of bone when I may need that bone for an implant? So our whole treatment planning decision may be entirely different than it was just a few short, years ago. And you have to remember that success and failure comes with your diagnostic decisions. That's it. If you make good ones, you get long-term success. Marginal ones, you're rolling the dice, and of course poor ones, we wind up seeing those as failures quite often. Like I said, different types of posts, and we've all seen these cast posts, and some of them are actually cast posts and crowns all in one piece. Many of them held up many, many years. Not a fan of them at this point in time. I've seen them crack many roots, but this was being done, and it's still being done in many places. We have these screw-in posts. Again, placing stress on the root. I'm trying not to place undue stress on the root. That's one of the things that we want to avoid. We don't want to open up that canal too big, so we have to use clinical judgment to make sure that we've got the right set of parameters when choosing the post and the post size and placing it into the tooth. And again, I won't tell you I haven't used these type of posts. I have in the past. They're not my type of go-to thing anymore, strictly because I think they do place stress on the root, and the last thing I want to do is split a root. We've had paraposts, and we've had flexi posts, and everybody's got a different post that's supposedly the latest and greatest thing. Let's face it, good clinical decisions, all of this stuff works. We know that. I don't care what we're talking about here. If we make good clinical decisions, we're going to have cast posts that work, para posts that work, screw-in posts that work. It doesn't matter. They all will work in the end. But it's also, you want to minimize your chances of failure, and you have to use good diagnostic decisions in order to get you there. But the latest thing, are these fiber posts. And they create a lot less stress on the root. We can make them smaller. We don't need as big a diameter in many cases. We also know that they're not going to strengthen the root, but we can bond these in. All the others we're not necessarily, we may be using cements, we even may be using bonding materials, but are they truly bonding the tooth? Trying to make that one solid block. That's what I do now, is I try and make one solid block between the post, the core, the remaining dentin, and I'm trying to hold things together as best I can, because in reality, that's what I need. I need that strength all the way to support the core material, but the core material really should not be what's supporting the prosthesis. You know, that's not what we needed to do. The core is there just for resistance and retention form, but the real key is the ferrule. The ferrule is the part that's going to make or break your final prosthesis. If you don't have a good collar of strong dentin, you will invariably have a failure. The post itself will give. If it's a metal post, in all likelihood, you may fracture the root, or the post itself may fracture, necessitating having to take the post out. So when we look at this, the ferrule effect is that collar of dentin. You need 1.5 to 2 millimeters. Don't guess, because in many cases we may have it buccal and lingually, but what about interproximal? Take out a probe if necessary and actually measure it. Yes, I know we can get away if we are missing a little bit here and there, but you have to have that good solid wall. And even if you have it and it's really thin, it's a problem. So the bigger that ferrule, the less chance that you're going to have a failure. And that's really the important part to it. And this is basic crown and bridge. The stuff we were all taught in dental school. The ferrule is what counts. We've all pushed the issues. I know it. I've done it myself. And in many cases, we pay the price by either redoing it, the entire thing, or ultimately the patient, maybe years later, winds up losing the tooth. So, again, length of the post, diameter of the post, they may be important things, but the reality is the most important thing is how much tooth structure remains, and do you have a good ferrule to support your prosthesis. When you do have a lot of tooth structure, it may not require a post. That's right, not every tooth that has endodontic therapy needs a post. That's what I was originally taught in dental school, that you put a post into everything, and you would, I mean, think about it. I've seen them. I haven't done one in probably decades, and probably not a lot, when we had those lower central incisors, and people would just blow them away trying to stick a post in them. The worst thing you could do to a tooth. You know, you've got small teeth, and you've got enough tooth structure, you don't need to put a post in it. And with our bonding materials and the strength of our either build-up materials or composites, in many cases, you can just put the core back, reestablish what was missing, and then go ahead and prep a tooth. The perfect example is this tooth here. We've got plenty of tooth structure left. You know, there's no reason to then start to weaken it any further by placing, a post into this tooth. So think about that. Not everyone is going to require that you have a post in it. Core buildups work very well. In fact, I would tell you probably 90% of the time I'm doing core buildups and core buildups alone. If I have to think about placing a post in a tooth, I have to now think, is this tooth restorable? It's one of the first things that come to my mind. Do I have an adequate ferrule? If I do, then I can place the post. If I don't, then I definitely need crown lengthening, or we need to talk about extracting the tooth, placing an implant, doing fixed bridge work, whatever we're going to do. But you have to remember, the first thing to evaluate is there enough tooth structure left, adequate ferrule to restore the tooth, because otherwise we're looking at failure, and we've got other options that we can easily use to restore teeth. So let's look at a case. All right, this is an older woman in my practice who has many issues. I diagnosed her with squamous cell carcinoma over a decade ago. She's still healthy and she's still here kicking. She lost a section of her mandible. She only has her lower anterior teeth, and that's it. As you can see here on the canine, on the right lower canine, she had a funky post put in it and some composite buildup that was wearing out over time. And one day she shows up and the thing is out of the tooth. So this is what I'm presented with, and if you look at the tooth behind that, that was when we were talking about making her an overdenture, and we didn't want to treat her post-radiation, so we left that in, and that tooth has been in there, like I said, for over a decade at this point. We've got this tooth here that we're going to need to restore, this canine. So, do we have enough tooth structure to support it? And the answer was yes. And then I have to determine appropriate length and diameter of post and all the things that go with it. You know, is the endo satisfactory? All of those things have to come into play, because is the foundation good enough to support the prosthesis? That's, again, what we need to determine at this point in time. And in this case, I said yes, and we are going to use Voco's Rebuild a Post system to rebuild this tooth. So here is, again, a different view looking down at the tooth. Post had come out, the core material, filling material had come out, and this is what we were left with. So I determined the twist drill that I wanted, and then, again, I'm going to now prepare the canal to accept the post. And there is the preparation of the canal. Quite quick, straightforward. I cleaned out any decay and any dentin, and you still see some staining there. But you know, that was quick and simple. And you know, using a twist drill, we just got in there and enlarged the canal. Then I took the post and I placed it into the canal, and then I marked it and just kind of determined where the height was that I wanted the post. You know, you can mark it with a Sharpie, you can mark it with, that's what I use. I have a Sharpie, and I just kind of draw a little line on the Sharpie, with the Sharpie, and take it out. And then I cut the post, and then we know where we're going with this. We're then going to, in this case, we're going to place some bonding material on, there's a special conditioner to place on the post to get it to bond, but then we're also going to need to bond into the canal. And for these cases, I use Futura Bond DC. It's a self-etch dual cure because, you know, again, are we going to be able to get light down to the bottom of that post hole? I don't know. There's going to be places that if I place all this in, maybe I can't get the light to cure it. So we want to look at a dual cure system so that if you can't light cure into some of the areas, it still will set. And we want to make it as easy as possible for ourselves. You know, don't leave this to chance. Don't use your standard bonding agent because we want to know what, you know, we want to make sure that we're going to have both dual cure and light cure. There was a question, I did see it now, what do you use to cut it with? I cut it either with a burr, I've cut it with a knife, I've cut it with a scissor. I think in this case I probably just cut it with a very sharp surgical scissor. To get those fibers out, you know, cleaved. But I do want to tell you about something new. I got some of this. I've tried it. This is the new Voco Futura Bond. The nice thing about this becomes your complete bonding system. You can use it for direct and indirect. It's self-etch, selective etch, total etch. It really doesn't matter. You can just use it for anything because it's both light cured and dual cured. So that's really a real plus now because you don't have to carry different bonding agents. I had dual cure bonding agents, I had my light cured bonding agents, I had all this other stuff. Now I only need one bonding agent if I want to just basically take care of all of my bonding needs. And I don't have to worry as much, did it cure or didn't. And this will work with both self-cure and dual-cure composites. And the nice thing is it also adheres to metal, zirconia, aluminum oxide. So no matter what kind of crown you want to put on this, you could actually bond the crown on, you know, with this bonding agent. It's coming out in the U.S. In September. It works well in my hands. I've only had it for about a week, but something to know about just to let you know it's coming. So we want to really know what are we doing. And bonding is really the the thing that we do in dentistry all the time now. We're going to bond. But you see a whole bunch of things. And like here, we talk about, how much do we need to adhere to dentin? Well, in this case, these materials are about 30 megapascals for their bond strength. But we also have to take in a little reality here. Because I like to say, well, how much is enough? And everybody says, oh, more and more, the higher the bond strength. I'm not so sure that's the case. What I do know is God gave us bond strength of dentin to enamel of somewhere between 17 and 20 megapascals. With that information, I know I don't want less than 17, but how much is enough? Look at what you're using and then try and determine, is it adequate for what you're doing? Both dentin, especially in something like a core buildup, where we're just looking at this current case where I have a lot of dentin versus enamel. You want to look at these things. Don't leave these decisions to what's ever on sale, what your assistant ordered. You don't really want to do that. You want to really understand the materials that you're using. I highly recommend going back and looking just at some of the basic research of any of the material, whatever bonding agent you use. I don't care which company's is. It could be Vocos, it could be 3M, it could be Kerr, Dentsply. It really doesn't matter. Look at those materials. Look at some of the research, preferably third-party research, and see, does this hold up over time? Where is it? Look at those adhesions. You want to look at those bond strengths. It's really important. And really read the instructions. Do not leave that to the assistant. Look at the instructions. It takes you 10 minutes. It'll make your life simpler. And you'll know what you're using, and you'll know why. Just don't do it blindly. I've seen a lot of dentists just think they know how to use materials, and something's different from one material to the next, yet they apply it all the same because that's the way they've been doing it. Whether you're using a 5th generation, a 6th generation, or a 7th generation bonding agent, you have to know why and what the advantages and disadvantages of all of them are. So I'm really big on selecting the right bonding agent, and you have to know why you're using it. Just don't use it and think, oh, it's the one I've been using for years. The nice thing in this Rebuild-A-Kit is they have these really nice long pointed brushes that are made to fit down the canal. Not the little brush with the little round piece on the end that you're trying to get in there. These are extended pieces that actually fit right into the canal, and you want to know that it's getting to the bottom. Not that it's seeping down, but you can actually place these quite a way to the bottom of the canal preparation space, spin them around, rub it into the dentin, and bring them back up. It's a nice little device. It's nice little, it's not a device, it's really just a nice little brush that somebody thought about how to do this. Instead of just using the standard stuff we always have, it's a nice little brush, and it fits right in perfectly into the canal space. So I use Rebuild-A DC, which is a dual cure composite that's in an auto mix gun, and we then started to build it up. Again, dual cure so that if there's something deep, I know it's going to set, because what I don't want to have is areas of unset material somewhere deeper into these preparation, which could be an area for failure. And that's what happened in the old days when we didn't have good curing lights. So another important part to anything, if it's not a dual cure material, make sure your curing light can cure it. And that means, the more that you have light getting to it, the better it's going to set. But if you can't get light there on a light cured material, it does not set. There's a question here about taking into effect the torquing event of occlusion, especially in the anterior and bicuspids. I agree. Again, this is all looking at what are we using, and how are we restoring it. So yes, occlusion is a big part of it, because those are the forces on the teeth that this is going to have to resist. Back to the ferrule. If you don't have enough ferrule, it's going to fail. We don't see a lot of loose posts when we're bonding them. I don't see a lot of loose posts from bonding. I have seen posts loosen up, whether they be cast or threaded posts. And sometimes we lose those posts no matter what because the system is overloaded. There's too much force. What did I use to create the post hole? The post hole was made, and I think I may be able to go back to that. Let me go back. The post hole was done with a twist drill. This was created with a twist drill, as you can see here. Nothing fancy, it just comes in the kit. And do I worry about endodontic sealers with eugenol prohibiting the set of resins? I don't, because usually if I'm placing this, first of all, I don't use a eugenol sealer. I'm using a Resolon-based system, so I'm not using that myself. And again, in a case like this, it had been there for years. I'm not really worrying about eugenol and bonding. But again, you may need to clean those walls. Use whatever you think you need to get that taken care of. So, all right. So we have the thing cleaned up. We've got the hole, the preparation, and now we're going. What I do is I inject the build-up material at this point. That's really what I want to do. Is I want to inject the material into the canal. And there's one other question here before I go further. It's the same. It's not exactly the same as Futura Bond DC. It's different. It comes in the same packets, but it's new and improved. It's different, and you can use it. It's got different indications. You can check it out on Boco's website. I then, after I've injected the post material, because I'm trying to make a monoblock here. That's the whole idea. I want it one piece. I then place the post material into the place the post into the material, into the tooth, and then I start the build-up process. And you can see I just built it up. It's the same ice cream type of thing. We just start moving it around, and it just flat out works. You just start building it up, and then I prep the tooth. After I've light cured it, and then what I usually do is, at that point, I usually let the patient sit up, give the patient a chance to rinse, and it's more about me giving myself time to do more. Give myself a break, let the material set, let the patient have a break, and I sit there and go, we'll do more in a little bit. We do the preparation, and then here was a crown that was placed. This was an Emax crown. You can kind of see into this here. The radiograph is next to it. You can determine the core material. You can see the post. There was no lesion at the bottom, and again, since this woman really doesn't have a lot of occlusion on this tooth, this should function for her many, many years to come, probably for the rest of her life. Like I said, she's an older lady. And what is the minimum length for a post? Okay, so now we're going to get into it. There is no minimum length. Obviously, there's maximum lengths, but you want to have a post that's going to go sufficiently into the tooth that's going to retain it, because there's a lot of different research on the post length and diameters. One of the things is that a too short a post is not going to do you any good. All right, it's not going to resist anything. It's not going to hold the core in place. So you want to be probably at least, I'm going to say 40 to 60 to 70% down the canal. You don't want to open it up too wide. Again, these are clinical judgments. Sometimes you can't get the post down further, and you're limited by the tooth, and you don't want to overheat the tooth when you're trying to prep it with the twist drill. You don't want to, make it too wide. There are some limitations here. You may not be able to turn a corner because we're talking straight line access. So the minimum is somewhere going to be, I'm going to say somewhere 30 to 40% of the length of the post. Depending on some posts, they'll tell you one thing, others will tell you no. You don't want to get too close to the apex because you don't want to break your seal. So you're going to want to stay, 4 or 5 millimeters away from that, because if you break the seal, now you have a failure based just on endodontics. Could I use a glass ionomer to seat the post? Of course, I've done that many times. But what I'm really looking for is greater bonding at that point. You know, the glass ionomer, I'm not sure. First of all, depending on the glass ionomer, do you have enough is it the viscosity is always the key to me when we're talking about glass ionomers. Some of them I don't ever feel are thin enough that I'm going to be able to then place that post in easily. You know, I may have to work it, or I didn't put enough material in and I'm trying to work it in. So I'm not a big fan. I have done some core build-ups and things with glass ionomer, but lately that has not been anything that I've been using for a post and or a core. Do fiber posts tend to fracture? No, they're the most forgiving in this, because they're meant to basically mimic the tooth, whereas when we're talking about, you know, where do you want failure to be? I sure don't want to be a failure in the root. That's the last place I'm looking for failure. If we have a fractured root, then game's over and it's time for an implant, and we need to be placing some titanium in there or a fixed bridge. If you're looking at, okay, something else is going to fail, now we've got that post coming out with the crown inside of it, and it may loosen at times, and now we always have that chance of recurring decay. So again, it's the kind of thing that, you know, it's a clinical decision. How much is enough? And, you know, you're going to have to make those clinical decisions. So another question about, you know, how far do you want to be from the apex? I'm going to tell you somewhere 4, 5, 6 millimeters away from the apex. Getting closer to the apex than that is a good chance that you may dislodge either the gutta percha, your Resilon, whatever material you're using, and then you may have an endodontic failure because of placing the post. When I'm placing posts or even doing a core buildup, the greatest chance of endodontic failure is not from the bottom up, but from the top down, coronal leakage. So if I'm doing my own endodontics, I will tell you that I want to make sure that I seal that area at the time of finish. I do my core buildups or I place my post at the time that I complete the root canal, because if I can bond that whole thing closed, I have a less chance of having coronal leakage and losing this tooth. We've all seen the teeth that have, you know, patients disappeared, they've broken down, and now they fail. And a lot of times the endo still looks good, but the rest of the tooth broke down. Yeah, that's the way I want it, is the rest of the tooth would break down, not my endodontics. And if I can do all that and do it well and seal the coronal portion of it at the pulpal chamber, I'm going to have much greater success. Aren't clear posts better for light curing deep into the canal? Absolutely, because you're going to transmit light through the post, whereas if you're using anything that's solid, you're not going to get any light transmission. But having said that, if you're using dual cure materials, it really is not very important, because you're going to get the curing, and that's why I would recommend using dual cure bonding agents, using dual cure buildups, because then you're sure that this stuff sets. Other than that, you know, it's a leap of faith that you were able to get enough light to the bottom. You know, think about it. How far are we down? And this is a whole different lecture on curing, but when we measure curing, what they do is they take the light and they place it on the radiometer. They put it right on top of it. Well, now you may be significantly down from there. You know, think about it. When you're doing a class 2 box, you're probably 5, 6 millimeters from where the light source is. If you're placing a post, you could be 10, 12 more millimeters from the light source. And as you get further away from that light source, you get a decrease in light, which means you would have to cure it longer, which most people don't do. So it's really something to think about, you know, not trying to use light cure only bonding agents and materials when you're doing these things into depths that may exceed what the light can cure to. To use intraoral sandblasting on a metal post before placing the buildup. I have done that at times. I don't do it normally. I've kind of switched over to these fiber posts in many cases. Occasionally I'll still put in a screw type post. I don't know if I'm doing it because I think I have to, or I think it's stronger or anything else, but occasionally I still use them too. There is no one-size-fits-all for anything in dentistry, and again, use your clinical judgment for that. Have I used a self-adhesive cement for the post? Yes, I have. But again, I can't get the monoblock that I'm trying to do, which is the entire buildup all together, one time, from inside to the post, because I'm bonding the post to the walls, one monoblock, solid all the way up. Can't do that in that situation. Are absorbent points the only material used to make sure the canal is dry? Yeah, that's what I use, paper points. I do have some other things, they do little suction tips, things like that you can try, but for the most part, using paper points. So let's go to another case. Let's see what else, because we're starting to get closer to the end here. Here's another broken down tooth, and we're going to run through this quick because the next case is really a good one I want to show you. So again, taking a twist drill in there, we're going to remove gutta percha. We're going to open up the size to what we want in terms of what we've already desired or hope to achieve, and we're taking out the filling material at this point. And there it is, looking down into the canal. Here we are using, again, that nice brush, that tapered brush that fits right into the canal. Very nice way to do it. We place the fiber post in. I've already trimmed it here. And we do the build-up, just freehanding it on. And then do the preparation. And you can actually see, right here, the post. Let me see if I can get this to work. Here we go. Right here. That is the fiber post. Right there after the preparation. You can actually see it right there. But here's something that happens all the time. And, we've all seen this. It can be a problem. What happens? You had the tooth. This was a zirconia crown. And now you thought you had enough tooth structure, and you didn't. And the whole thing gets loose. And now you've got an upset patient. Might not be, you might have had what you thought was a good ferrule and everything else, and this may have lasted a while and you were okay and happy, or it could have been you made the wrong clinical decision here. But we've all seen cases like this. Took the tooth, took the crown out, removed the material that was inside it with a drill, then I took it over to the sandblaster and cleaned it up. Real simple. We went from what's on the left side there to the right, nice and clean. Prep the canal, just like we'd always wanted. Place the post into it, mark the post, cut the post, placed it back in to check that it all was what I wanted it to be. What I normally do is I then place a little bit of Vaseline inside the crown, because what I'm going to do is actually do a reverse core buildup here. So I don't want it sticking to the crown. That's the last thing I want it to do. I place the bonding agent on the upper left there. I place the bonding agent onto the post. I then go in and place the bonding agent, and they're different materials here, so I don't want you to think that it's the same thing. Place that. I dried it off. We let it cure. We place the build-up material into the tooth. And then we place the fiber post in. I'm going to answer everybody's questions, though, at the end, because I want to get through showing everybody the cases. So any more questions I'm going to answer at the end. And there we have the post inside the canal. I then load the crown with the material and place it back onto the tooth, have the patient biting it into place, because I want to make sure this thing is fully seated in the right orientations, buccal, lingual, mesial, distal. It's got to go right back in perfectly. And you can see the excess coming out around the gingiva there. And this is what I get after it has dual cured. All right? We leave it there for a few minutes, let it dual cure, and then gently bring the the crown off the tooth. That was the whole purpose for placing the Vaseline inside the tooth. I then go ahead and prep the tooth back, all right, being very careful to try and avoid the margins. I do not want to alter the margins of this tooth. What I want to do is just remove the flash. So I might do it with some finishing burrs, like an ET9, or I might do it with an Explorer or a scalpel. It all depends what I think I need to do to get it done. I then clean the inside of the tooth with alcohol. In this case, I might use some IvoClean if that was necessary, but I kind of switched to Ceramir, which is a cement that does not require preparation for a zirconia crown. I then place the crown back in, make sure the occlusion is correct, and there we have the reverse post and core done on this tooth, and it's been functioning fine and dandy since we've done that. So again, you want a dual cure because, again, there's no way for me to have light cured this material in this case. You want to make sure you have a dual cure. Other things you can use Grandio, which is a Voco product. I've used Build It from Pentron. I've used a whole bunch of different things over the years, but you want to make sure whatever you're going to use is dual cure in 99% of the cases because you're not going to be able to get light to many of those areas. You want your core material to be sufficiently hard so that you don't over prep it, you don't ditch it. I know some people use old composite to do that. I mean, these are all just things that we need to look at, but you know, there are materials that are made to make your life easier, and like I said, here, I use Grandio sometimes when I'm using core only, because it's a little more stiffer material, and the rebuild flows a little easier. So I'm sure I can get it down into the canal, place the post without any real effort. Whereas Grandio's, again, it's a little thicker material, a little more viscous, and you have to know that. It's got a little bit more ability here when you're using Grandio. It's got a little more radiopaque, but they're both going to work for you. If you don't want to keep them both around, choose one or the other. But what about just the core? Well, we have to have adequate tooth structure, like I showed you before. Must have a good ferrule, all right? Use of dual cure, good bonding agents, and then you're going to just prep the tooth for to an ideal preparation. So in this case, we use some Grandio. Again, it's got good radiopacity. It's stackable. I mean, all the things. I like ones that come in different colors. My preference is blue or white. Especially if I had a deep preparation, I like blue because I can get down on that preparation and I can really then see the difference between tooth structure and, tooth. That's one of the reasons we're looking at blue. I'm not a big fan of the dentin because I don't want it all kind of blurring together. I would use that possibly in an anterior case where I'm going to be using some Emax crowns, and I want to keep that color, as natural as possible. My standard ones are the blues and the whites, and I've used those no matter whose materials I've used before. The one I was using before these, I was using Pentron's Build It, a very excellent product. Again, using blue and the white. So we got this tooth that's severely broken down. It's fractured on the lingual, as you can see. We pull all that stuff out, and there's still enough ferrule, there's still enough tooth there, but there's a lot of tooth structure missing. I prep it, I make sure there's no decay in it. We're going to use some bonding agent. We're going to start using the build-up material. Then I'm just going to prep the tooth, normal, your normal preparation for whatever type of crown you're doing. Remember that. It's not one size fits all on your preparation either, whether you're using, a PFM, whether you're using zirconia, Emax, and just prep the tooth. And there we go. It's fully prepped, ready to go, and real simple, just a core buildup. Nothing fancy, stuff done every day in dental offices all over the world, just like yours and mine. This is what we do. So now it's on to questions. I do have some backed up here, so I'm going to get to them in a second.